I'm going to do a real whistle-stop tour through the themes to give you some idea about the flavour of what's come out under each of the themes. And because there are 9, and I've got about 10 minutes, it's going to be really quick. But first of all, the evolution of treatment was a huge area that people talked about. We've seen sort of 4 main themes out of that, which is the early years, the wasteland years, which Mike Yule termed as the phrase, testing, how important that was, and the Lazarus effect, which people are familiar with that term. And of course, you know, this meant things that we were dealing with the unknowns and what that meant. We heard stories about people's first memories and their first patients. People talked about those wasteland years as being really problematic in terms of the number of deaths and the opportunistic infections, and not really anything moving in terms of what, you know, therapies coming up that were effective, and certainly to see the sort of rise of alternative therapies as well. And testing, of course, raised lots of dilemmas for the people that we interviewed, in the sense of, you know, what was it the value of testing, if, you know, or the burden of testing if there's no treatment available. And yet, obviously, also we saw the changing debate around pregnancy because of some treatments coming up online that were beginning to be effective. And the Lazarus effect, you know, a fantastic story, a fantastic thing to be a big part of, because people were living and not dying. But of course, at the same time, the impact of services closing that people had been part of, that had been part of their lives, the side effects of medication that people were having to manage, and the psychosocial impact of some of those changed expectations, are some of the things that we're living with, obviously today as well. So a hugely packed part of the project was around this theme. To go on to look at responses and attitudes, we divided it into looking at, you know, from the public, from patients and the relatives and friends, from other healthcare workers, and also quite often those were negative, but then there were the positive responses of the people that came to work in HIV, and it highlighted very much the importance of confidentiality, and how confidentiality meant something very different to the people that we interviewed. And if you look at the next slide, there are all sorts of stories there, comments that people have made about the fear that people, of the public around infection, the negative attitudes towards lifestyle, towards HIV, the challenges that people faced that were working in HIV were huge at that time because of these responses and the difficulties that people faced. On the other hand, there was the unexpected compassion from areas like people talked about BA workers, how much they contributed to raising money, to being there for people. Obviously, Princess Di came up quite a lot because of the nature of what she was trying to do, how she changed attitudes. Of course, there was people expressed the difficulty of seeing patients rejected by their families, and also experiencing their own rejection for working in HIV in the first place. So there were a whole range of areas that people were tackling with. And then finally, the difficulty of knowing that when you made a referral to another department, that referral might be rejected by your co-workers, your colleagues in another department. And so we were talking earlier about that, the feeling of jealousy of the amount of money that we had within our service, that came across from some of our co-workers. But of course, what was being developed as well, in the context of this response and attitude which was negative, was a group of health workers that became activists, that were advocates, and that was talked about a lot within the interviews. The next area, very important, is the changing approaches to healthcare. And there are 3 areas of this. There's the new patients, there's the new healthcare approaches, and there's the new healthcare workers. And people talked about how young people were, that they'd been previously healthy, the difficulties of stigma and the stigmatised communities that we were managing, and the psychosocial needs of families. Those were people that we were identifying with. The new approaches to care were clearly, the word you heard so much was about partnerships, about patient-centred care, the innovations that we were able to make, and the importance of the multidisciplinary team. And of course, rule breaking. I mean, rule breaking comes up a lot, and it came up also about having more relaxed professional boundaries than perhaps we see now today. And then, of course, the new health workers themselves. So doctors and nurses on a very different plane, that sort of flattened hierarchy. People talked about the fact that being gay and a health worker, this was a safe place to work. It was also a place where HIV positive people felt safe to work as well. And of course there was a huge amount of commitment, and people talked about friends. Are they patients? Are they friends? They're both, and what that meant. And of course volunteers as well were very important in this as well. Relationships is another huge area, and I'm not going to say very much about this other than that we saw huge changes, or people talked about the huge changes in the traditional relationships between health workers, the relationships between health workers and their patients, and also those different relationships and support that people gave to families and friends and partners of the patients. But I'll let Geraldine, who was a nurse at the time, talk about her experience.
We had the most amazing group of volunteers at Chelsea Westminster. Jean, I can just see Jean. She was this mother that looked after the volunteers, and her son had died of HIV, and she and the other volunteers replaced their parents, those people that didn't have parents, that hadn't told them. They were there every day. They made the most amazing food. They gave the most amazing care and love. And we couldn't have looked after people the way that we did without the support of that voluntary service. They would relieve people's parents. They would relive being someone's parents. And I think the volunteers made it a lot easier for the parents to be around.
And I think just to add to that, those are the unsung heroes within this epidemic, including some of the domestics that we work with. But unfortunately, we didn't interview in this. But there's always time for a few more interviews if we can make it. So death and dying is another area which people talked about a lot. And again, the sort of sub-themes that came out of that was the challenges of the complexity and distressing issues that people were dealing with. Funerals were talked about a lot as well, and we'll go on to just look at some of the things that were said. And then the important role of being able to assist somebody to a good death, and what that meant for the people that were involved. So if you think about this, and unfortunately that is a picture of me. I'm a lot older then, I think. So first of all, the complexity of the issues that were faced by the people we talked to. Nursing and being a doctor to friends and to colleagues who were on the wards. The volume of patients coming through and dying, and the age of those patients, and that being the same age as the people that we talked to. At that time, there was that synergy. The family dynamics, some of the stories of both the positive and the negative were hugely moving about how health workers had to step in where the family dynamics had rejected their loved ones. Child death was talked about, and the impact that had on parents who also were facing their own death. And of course here I have to mention the Scottish mother's experience, because the Scottish story Those women were seeing one adult child die after another adult child die, and knowing that the next adult child would die, and the devastation to those families. Funerals was another thing that was talked about a lot, and there were differences between people's thoughts about whether they should attend or shouldn't attend. And there were lots of good reasons why people didn't feel like they wanted to attend. They felt there might be an intrusion on the families. There were issues of confidentiality, because if you were recognised in a funeral, then that might mean that's blown the identity and the confidentiality of that patient who died. Some people just said they'd been to too many, they couldn't do it anymore. But of course, people also talked about the positive aspects of planning funerals, which is something that, you know, I think has had a reverberation today, that you see a lot more people talking about planning their funerals, and I think that comes out of that. And then, of course, the role of assisting people to a good death. And the words that come out time and again from the interviews is privilege, the fact that we could be open and honest with people about facing their death. The personal growth that people identified that happened to them being involved in that. And also that meant that those new approaches to care that the teams had built extended into end-of-life care as well. And it was seen as a very positive role by many of the people that we interviewed. Transmission and health promotion is an interesting area, I think, because a lot of the themes that I've dealt with so far, there was quite a lot of commonality across those themes and the sub-themes. But actually in transmission there were different issues being dealt with different teams, depending on what the transmission of the HIV virus had been. So for example, the challenges for our Scottish colleagues came out very strongly about the difficulties of putting often their own jobs on the line because of implementing harm reduction in the face of the difficulties of the legal situation and opposition, and really standing out on a limb. Also the impact of infection through blood products was important in that the emotions that came out of that, the anger that was expressed, the difficulties of giving a young person an HIV diagnosis was spoken about. And of course, the mother-to-child transmission, that was another story about making sure that people understood that things are changing in that, and with testing that meant a big difference to what could happen. And just to mention also the early days, the very early days, about when we didn't know what the transmission route was, the occupational fears that some of the health workers faced and faced up to, and the development of infection control, but the difficulties of using over-the-top infection control at a time, reflecting back on this, knowing that actually all the patient needed was a hug, which is what somebody said, and yet they'd been approached with all the gear on, which made it very difficult to give that hug. So very moving stories. And then of course health promotion, there was a lot of clinically led health promotion in conjunction with the community, particularly with a lot of the gay activists, that was done as a joint thing, and public campaigns was seen as the role. The Don't Die of Ignorance campaign, I think we did pick up on divergent views, so people who thought that strength of message was really important and had an effect, and there were some who felt that was stigmatizing, and that's a debate that continues to roll on. The popular media came up a lot. I mean, obviously we asked questions about that, and popular media, the soaps, the impact of EastEnders was important at that time. People remembered Philadelphia and how they felt. I remember crying as the credits rolled up, let alone seeing the film. I've just, and people spoke about how difficult that was to watch, and yet how important it was to get a message across. And then Princess Di, Again, you know, there's a play that's been written recently about that moment she came and opened the ward, but people talked about the impact that she had on the public perception of HIV and people who'd met her and how important they thought she had been. And we could probably publish a book with just the stories about Princess Di. And of course then there's the negative media, the sensationalism and the misinformation that came out of that. And then to just very briefly look at education and support, there was a whole range of different types of education. There was a lot of work preparing staff for coming into HIV, and that readiness to anticipate what needed to be done, and dealing particularly with their early fears, not just of the people working in HIV, but also other colleagues in other departments, because the patients were going to other departments. There was a lot of informal education as well from the patients. People talked about learning about sexuality, about sexual practices that were very important to know to be able to deliver that sort of care. And of course experiential learning, and there are quite a lot of humorous stories about experiential learning when people were being asked to examine or describe their own genitalia, and this was thought to be very important for people who were working in HIV at the time. So if anybody wants to, Nick has probably got the best stories of it. Formal education. The formal education actually was quite slow to take off, and I think even today people might be critical of actually how much education there is within the medical curriculum around HIV, and certainly that came up. But of course also people talked about their role in developing specialist courses, which was so important for people to take a little step back from what they were doing and being able to immerse themselves in discussions and the impact it was having on themselves. We saw the foundation of our professional bodies, and also then the staff support, and a lot of that was informal socialising, offloading, and generally drinking, and then the formal support, where it was discussed about people demanding supervision and actually using supervision in a way that they'd seen used in other specialties, particularly mental health, which says a lot about the sorts of issues that people were facing at the time. Impact on self. We asked this question specifically because we wanted to know how's it felt doing all of this, and of course it's divided into negative and positive. I think to start with the positives, people found it an intellectual and academic challenge and excitement to be working in this new field that was developing so quickly. There were new, as I've talked about, new ways of working, new perspective on people's own lives. They talked about how it had impacted to change their perspective on what they were doing themselves. And people talked about pride, the pride and privilege of working in this area. And the new relationships, and somebody described it as the exclusive club. Again, drinking came a lot in this, and the fun and the parties, because we were all a lot younger then. And the immersion in work life. But of course there is a negative side, and the negative were, in those early days, a huge pressure, huge concerns for personal infection, the helplessness that people felt, and of course that led people to talk about their own experiences of burnout or depression, and sometimes occasionally suicidal thoughts. And of course those long hours of commitment that people put into providing care meant also that they felt, and they reflect back now on how they neglected some of their families and partners, you know, and perhaps not feeling that their children had seen them much when they were in their growing years. And for gay staff, there was the difficulty expressed of being able to try and get away from it. And just listen to David speaking about his own experience.
I think I was well supported. But of course, I'm single, I lived alone, I would go home to an empty house with a lot of these stresses. People would often phone me at home, so it wasn't a 9 till 5, it was often working in the evenings. I can remember going out on weekends as well, bank holidays, if people needed you, I was there really. So it became a way of life more than just a 9 till 5 job. And with hindsight, perhaps that wasn't such a good thing.
And I think from the team, I really thank people for being so open about the impact. Some of it was very emotional and very important for us to be able to capture that in this story. And then the last theme, you'll be pleased to know, is telling our story. So we asked people, why did you want to do this? What did you, and how does it feel now you've done it? And of course, people talked about, we're all getting older, some people have died, and we've not captured their story, so we didn't want to lose that history, because people talked about it being unique, extraordinary. The Scottish story, we've just had an article published in a Scottish newspaper exactly talking about the need to preserve that Scottish story, which was so different. And of course it's there for posterity, and it's there for our future colleagues who are going to be working with the patients who are living with HIV. And also we wanted, as Brian said in the clip that we half clapped over, was about the seldom heard voices. There are people that we interviewed that have been interviewed many times, but there were people who came forward, or we chased, who were those seldom heard voices. And people talked about privilege again. The privileged word came up in so many of the themes. And the feelings about being interviewed were mixed, because people felt, great catharsis in being interviewed and energised by it. And people talked about it being fun. But there were people who felt quite sad, felt uncomfortable and vulnerable about going through some of these stories. And somebody said that they really wanted to get it right. They were nervous that they won't be able to get it right for the patients and to do them justice, which I think is a really important point to make. And again, privilege comes up. So those are the 9 themes. And I want to finish with a quote from Simon Barton, who I don't think is here. But what Simon is here. You are there. Good. Well, you can listen to yourself. But you probably do that quite a lot. Anyway, I thought I'd inject a bit of humour, always with Simon, of course. What Simon talks about, which is so important about this, isn't just about HIV. This is also about what happened in HIV, impacted on healthcare in general. What did we achieve through that? And Simon puts it really succinctly.
I think that although the HIV pandemic resulted in the deaths of millions of people, the way in which societies around the world addressed it was a stress test for their humanity and for their ability to understand that confronting an infectious disease which was sexually transmitted as well as bloodborne transmitted, was something that required more than just a medical response. It challenged politicians, it challenged society, challenged the media. And I think the role of clinicians, doctors, nurses and others, and the role of patients in that solution finding has been of benefit to healthcare.
And that is the 9 themes.